Hello, everyone, and thank you for joining me today. My name is Nhi Nguyen, and this presentation is titled Ethical and Legal Consideration in ICU End of Life Decision Making. It was created as part of my coursework for HCL 520, Legal and Ethical Principles at Grand Canyon University, under the guidance of Dr. Lashandra Spam. In the next several slides, I will walk you through a real-world inspired case involving a critical ill ICU patient with severe brain damage who does not meet Arizona's legal criteria for brain death. This case explores the intersection of medical care, family conflict, ethical decision-making, and state law. We'll examine key ethical principles such as autonomy, beneficence, nonmaleficence, and justice, as well as relevant Arizona statutes and hospital procedures. This presentation aimed to not only break down the legal requirements in such cases, but also to shed light on the emotional and moral complexities healthcare providers often face. I hope you find it insightful and applicable to your future work in healthcare leadership or clinical practice. Let's begin. In this case, a 45-year-old patient has suffered severe brain damage due to a car accident and is currently intubated. However, he does not meet Arizona's legal definition of brain death. According to Arizona Revised Statutes 141107, death is determined by either irreversible cessation of circulatory and respiratory functions or all functions of the entire brain, including the brain stem. Since the patient doesn't meet these criteria, he is legally considered alive. PMC, the prognosis indicates possible survival with long-term life support, but the family is divided. Some members reference the patient prior wishes, while others suspect financial motives. This division is causing distress among ICU staff and disrupting care. Such conflicts can lead to moral distress among healthcare providers, impacting their well-being and the quality of patient care. It's crucial to address these issues promptly, ensuring that decisions align with legal requirements and ethical standards, while also supporting the healthcare team. The patient requires mechanical ventilation and intensive care, with neurological recovery remaining uncertain. Long-term support may be needed indefinitely. The absence of a written advance directive complicates decision-making. Arizona law emphasizes the importance of advance directive in guiding healthcare decisions. The lack of documented patient wishes places additionally emotional and operational strain on the ICU staff. Healthcare providers may experience moral distress when unable to align care with what they believe the patient would have wanted. This underscores the need for clear communication, ethical consultations, and support system to assist staff in navigating such a challenging situation. Arizona Revised Statutes 141107 defines legal death as the irreversible cessation of circulatory and respiratory functions or all functions of the entire brain, including the brain stem. Since the patient does not meet these criteria, he must be treated as alive. In the absence of a written advance directive, surrogate decision-making is guided by ARS 363201 to 363203. These statutes outline the hierarchy and responsibilities of surrogate decision makers. Understanding and adhering to these laws is essential to ensure that decisions made are legally sound and ethical appropriate. Given, given that the patient does not meet the legal criteria for brain death, life sustaining care must continue. Under ARS 36, 32, 31, the patient's spouse is recognized as the default surrogate decision maker unless legally contested. Any decisions regarding the patient's care must align with Arizona statutes and documented procedures. It's imperative to ensure that all actions taken are within the legal framework to protect the rights of the patient and the responsibility of the healthcare providers. In this scenario, several ethical principles come into play. First, autonomy, respecting the patient's values and previously expressed wishes. Second, beneficence, promoting the patient's well being. Third, nonmaleficence, avoiding harm such as prolonged suffering. Fourth, ensuring fair use of healthcare resources and equitable care. Balancing these principles requires careful consideration, especially when the patient's wishes are not documented and family members have conflicting views. Engaging ethics committees and facilitating open communication can aid in navigating these complex ethical landscape. The absence of documented patient wishes and the division within the family present significant ethical dilemma. Inheritance concerns raise questions about motive, potentially influencing decision about the patient's care. Healthcare providers may feel caught between family factions, impacting the quality of care delivered. Addressing these dilemmas involve facilitating family discussions, possibly with the assistance of mediators or ethics committees, to ensure that decisions are made in the best interest of the patient and in line with ethical standards. Hospitals should have clear policy regarding end-of-life decision in the ICU. This includes verifying the surrogate decision maker, procedures for ethics consultations and mediation, and documentation standards for high-risk cases. Ensuring that these policies are followed helps maintain consistency in care, supports ethical decision making, and provides a framework for resolving conflicts. Regular training and awareness of these procedures among staff are essential for effective implementation. To uphold ethical integrity, the hospital's ethics committees should be convened immediately to review the case. All legal documents, such as the marriage certificate and any power of attorney, should be examined. Providing family mediation services can facilitate discussions and helps resolve conflicts. Open communication and thorough documentation of all decisions and conversations are vital. These steps ensure transparency, support ethical decision making, and protect the rights and interests of all parties involved. Ensuring compliance with both legal and ethical standards is essential when managing end-of-life care, particularly in complex ICU cases like this one. First, all healthcare professionals involved must be trained on the relevant Arizona laws, such as ARS 141107, regarding the legal definition of death, and 363201 to 363203, which outline surrogate decision-making procedures and the legal status of Advanced Directive, Arizona Advanced Directive Registry 2023. Ongoing interdisciplinary communication is key. Physicians, nurses, social workers, chaplains, and legal risk personnel should meet regularly to ensure everyone is aligned on the plan of care. Consistent, well documented assessment of the patient's condition should be performed to monitor progress or lack thereof, ensuring decisions are medically and legally supported. Legal counsel may be required to confirm that actions taken, especially in high risk or disputed cases, strictly adhere to Arizona statutes. As Kaiser and Kaplan 2020 noted, such proactive collaboration and documentation not only protect the patient's rights but also reduce moral distress and legal liability for providers. By staying complaint and transparent, healthcare teams foster trust among family members and reinforce the integrity of institutions' care standard. In emotionally charged ICU cases, it's important to activate a full network of support resources to guide decision making internally. The hospital ethic committees plays a central role in reviewing ethical dilemmas and providing guidance. Legal or risk management teams are essential for navigating compliance with Arizona statutes and institutional policies. Social workers and chaplains offer vital emotional and spiritual support for families struggling with grief, confusion, or conflict. Externally, the Arizona Advanced Directive Registry is a state supported database where advanced directives, living wills, and healthcare powers of attorney can be assessed. If previously filed by the patient, Arizona Attorney General's Office 2023, if needed, hospital can also reach out to third-party mediators, bioethics consultants, or even state ombudsmen to help resolve disputes that threaten to escalate legally or publicly. Kim and Choi 2022 emphasized the value of institutional support and teamwork in reducing stress and improving the quality of end of life care. Ensuring that staff and families know where to turn for support and doing so early can greatly reduce conflict, delay, and emotional burnout. It also ensures care remains centered on the patient's best interests. To summarize the appropriate administrative actions for this care, first and foremost, life sustaining treatment must continue since the patient does not meet the legal definition of brain death under ARS 141107. All staff must understand that any premature withdrawal would not only violate medical ethics but also breach state law. The spouse is legally recognized as the surrogate decision makers unless a court order or advance directive designates someone else. Per ARS 36, 32, 31, however, because the family is divided and there are concerns about motive, the ethic team should remain involved in all decisions to mediate effectively and ensure transparency. Staff must continue to document all assessments, conversations, and actions thoroughly. Support for ICU staff should also be prioritized. Moral distress is a real risk when providers are caught between conflicting family wishes. Kaiser and Kaplan 2020. By following the law, using all available ethical and emotional support systems, and focusing on clear communication, the facility can maintain both legal compliance and ethical integrity while doing its best to honor the presumed wishes of the patients and uphold high standard of compassionate care. ICU staff often face emotional exhaustion when end of life cases become ethical and legally complex. In this scenario, the lack of consensus among family members and the absence of a clear patient directive put staff in a difficult position. Nurses, in particular, may develop moral distress when they feel the care being provided is not in the patient's best interest, especially when they suspect ulterior motives such as financial inheritance concerns. Kim and Choi 2022 highlight how end-of-life care stress negatively affects performance and well-being. Their study found that nurses with higher resilience and a strong sense of professional calling experience less distress and perform better, when these emotional challenges are not acknowledged or supported. Staff morale, communication, and quality of care can all decline. It's essential that institutions provide structured emotional support system, including debriefing sessions, peer support, and access to mental health professionals. Investing in staff well-being enhances ethical integrity and reduces burnout. Long term, such support can help ensure consistency and compassion in care, even in ethical ambiguous cases. Kim and Choi 2022. This case echoes many past ethical debates in ICU care. The Institute of Medical Ethics Working Party, 1991, emphasized that withdrawing life support is ethically defensible when the patient is in a persistent vegetative state and lacks awareness of or recovery potential. Although our current patient does not meet brain death criteria, similar moral questions apply. Are we prolonging life or merely extending suffering? Without a written directive, we deepen heavily on surrogate judgment and documented state law. Legal clarity doesn't always translate to emotional acceptance, especially when families hold conflicting beliefs or suspect unethical intentions. Likas et al. 2016 point out inconsistencies in how brain death is interpreted legally and ethically, especially across jurisdictions. This reinforces the importance of standardized policy and clear, compassionate communication. Moving forward, institutes should also improve public awareness around advanced directive and consider using family-centered communication protocol to reduce conflict. This approach not only ensures compliance but builds trust and emotional safety for everyone involved. Nikas et al. 2016, Institute of Medical Ethics 1991. As we conclude, let's bring the focus back to what matters most: preserving patient dignity while navigating complex ethical and legal realities. This case illustrates just how complicated ICU end of life decision can become when legal definition, family dynamics, and unclear patient wishes collide. However, it also reveals opportunities to strengthen ethics training, improve communication protocols, and support interdisciplinary teams emotionally and professionally. We must continue to encourage patients to document their wishes through advance directive while they're healthy and competent, reducing uncertainty during times of crisis. For healthcare professionals, ongoing legal education and ethics support are not optional, they're critical. Use resources like ethics committees, legal counsel, and communication frameworks to guide your actions. And remember, it's okay to pause, ask for help, and work collaboratively toward resolution. Ultimately, our shared goal is to deliver care that honors lives, support families, and uphold the law. Thank you for your attention and for your commitment to ethical, compassionate care. Bye now. And this is the reference slide. Thank you so much.